Welcome, everybody. It's great to see you all, and thank you for joining this session. I know all of us are really excited to learn from Tia and Candice. We have two wonderful panelists today. Dr. Candice Biernesser is a behavioral health scientist and licensed clinical social worker, and she is assistant professor of psychiatry at the University of Pittsburgh. Her interests focus on adolescent suicide prevention, the study of social media experiences, and the development and testing of digital interventions, particularly for Black and LGBTQ plus youth. Her current research focuses on examining ways to mitigate the impact of negative social media experiences, particularly focusing on online victimization, given its close link to suicide risk among youth. And Dr. Tia Dole is the Chief Suicide and Crisis Officer at Vibrant Emotional Health, overseeing the administration and all operations of the 988 Suicide and Crisis Lifeline, which seems like a massive, massive task. Uh, she is a licensed clinical psychologist and a longtime advocate for the rights of those with intersectional identities. And her passion lies in helping people get access to services and normalizing mental health conditions, especially within communities of color and LGBTQ plus communities. Dr. Goodall previously was the Chief Clinical Operations Officer at the Trevor Project, which, as many of you know, is the world's largest suicide prevention and crisis intervention organization for LGBTQ plus youth, overseeing all of their crisis service programs as well as their volunteer community. I'm going to turn it over to Tia and Candice to briefly introduce themselves, note their connection to this topic, and to please note any conflicts of interest or relevant disclosures at this time. And everyone, please feel free to either raise your hand or ask your question in chat. I'll try to keep track of the order and we'll fit in as many questions as we can in the next 48 minutes or so. But first, let me turn it over to you, Dr. Dole.
Great. Nice to meet everybody. I'm a clinical psychologist, and I've been running 988 for 3.5 years. And right now we're serving upwards of over 9 million people a year. And it grows about 1.5 million interactions every year. It's growing. And actually recently we discovered that for young people who use 988 in high utilization states, actually have a decreased suicide rate. So we're extremely excited. And if you're interested in the JAMA note, I'm happy to send it along. So, anyways, my intro is too long already. Just a pleasure to be here. And I'll just, as a side note, I love questions. I like hard questions, and I have a very straightforward style. So feel free to utilize that method as well. Pop it over to Candace.
Hi, Candice Biernesser. I appreciate the introduction already. And I would say with other colleagues at Pitt and in other places, we have done work in thinking about developing smartphone apps around safety planning and text messaging interventions in the suicide prevention space, particularly with adolescents who are experiencing online victimization, and we're thinking about chatbots and a lot of other things. I really love digital mental health in this field and suicide prevention, particularly among youth, but among everyone. And I'm happy to be here with you all and to have a conversation together about this really important topic.
Wonderful. And have you both had a chance to make any disclosures or conflicts of interest that you need to share?
None.
Same.
Okay, that was easy. I'll start us off with a question, and then others, as I said, just add them into chat or raise your hand. Digital tools are being used in many different ways or explored in many different ways for suicide prevention, which is really exciting. I put just a few of them into chat because it's a bit of a mouthful to read them all, but screening, safety planning, crisis support, follow-up care, peer support, real-time risk monitoring, among others. And I'm curious to hear, I guess, where you're most excited, where you see the most potential, and what's guiding your response there.
You you want me to? I can go first. What's interesting, when you say digital, of course, my first thought goes to AI, just as a FYI.
Okay.
One of the things for me, because we run a network, we have like 14,000 crisis counselors who respond to calls, chats, and texts and 988. And the thing I think about is actually helping people, counselors, clinicians. I like digital tools, less so for the help seeker, which I know Candice is the opposite, right? She loves her digital tools. But I actually like digital tools for the person who's doing the intervention, the person helping, for lots of different reasons. I love it. I love where we're going with like QI. I like where we're going with like supporting the crisis counselor, getting real life feedback while they're on the line, for instance, or even, I just think for me personally, that's where I'd like to see our digital tools go to support people who are in service. So I'll stop there and pa pass it to Candace.
Yeah, I think in looking at that list, it's difficult because I think there's a lot of potential in all of those different areas in different ways. Acknowledging there's huge differences for different kinds of outcomes and populations and so forth, but I think there's huge potential in thinking about ways to increase efficiency with this with assessment and thinking about ways for the real-time monitoring piece is a huge and growing area. I think it's such a hard thing to really know when these moments when someone is really at risk. The ones who reach out, it's we don't necessarily always even have the resources, though, I think, for those who are reaching out. So that's another thing I think a lot about that. I love this the opportunity to use the massive amount of data that's out there to efficiently assess risk and also to learn about it in real time with all the different methodologies that are out there, from passive sensing to electronic health records. Dr. Moore did a wonderful job going through a landscape of all the different literature and the ways that we can really pick up on risk in a lot of different ways. And I also think about that piece that I'll mention again of just what do we do do we have the resources to respond in those situations. So I mean, I'll be honest, my bias is that I do think that increasing our infrastructure around crisis response, around safety planning is really crucial in the midst of that. And it's not just because I knew I would be here with Dr. Dole today. That was my answer before I knew that. But I do think that it's really critical. But again, I think all of these areas are really, really important for reaching people where they're at and the time that they need it, in environments that feel comfortable, and trying to find ways that can be scalable in an environment that we don't have all the resources that we ideally should.
And I appreciate that. I think following up, one of the things that David Moore talked about also in his talk is the challenges of implementation, right? So that we have these tools, there's good evidence for them in some small controlled studies, but challenges in getting them to be sort of effective in real world environments. I'm wondering if you have advice particular to thinking about that in the suicide prevention space, about how development should occur so that it is deployment focused and has that best chance of having the reach that we hope it will.
Yeah, I can start with that one. I think the there's a lot of different pieces of this, but the one that comes to the forefront of my mind is who are we including on the in the on within the table when we're actually building these things? Are we including, if it's, for I'm going to use young people because that's who I work with, but are we including the young people themselves in that? Are we thinking about that in a way that has that mindset of, if I'm actually having my worst day, if I'm in a crisis situation, how would I want to approach this? What feels comfortable? Or, if I'm not, maybe I'm a person who has these kind of thoughts on a regular basis, but I'm actually doing kind of well right now. How can we be flexible in a way to meet people in various different states? But I think at the end of the day, we'll never get those insights if we don't include those folks in the process of it. And it's good science, but I also think that it gives a voice to people who don't always have one. And also not just the individual themselves, but those in their support network. If we're depending on the situation that we're working in, the providers who are working with them, folks within health systems, we really have to include all these different angles from the onset, I think, but also thinking of how can it really be implementable long term? How does it fit within the billing strategies that exist? How does it fit within the regulatory pathways? And there's this really hard piece of it that is complicated, I think, of how does it financially sustainable too, and environments when it's always hard thinking about that, and because the vulnerability that comes along with this topic. But we do really need sustainable pathways to keep things moving. So that we can have the kind of consistent response that we need for these vulnerable situations and vulnerable populations.
No, I appreciate that. Tia?
I think the interesting thing about tools is the tool is generally only as good as the person using it. And so anytime you have like a tool that's evaluation, right? So if you're going to do the CCSI, which is a suicide risk assessment, if you have a person who's not very good at giving them, give it to someone, you're going to get bad information. And if you have someone who's good giving it, you're going to get good information. And the person who's good is the person who usually goes off script. And is actually like responsive in the moment to the individual in front of them. So I can't tell you how many times, I was like on an inpatient unit and they'd be like, "Oh, they're not suicidal." And I go and I speak to usually a young person because that's my favorite group. And I'll come out and I'm like, they have a gun. Their timeline is in 3 days. And they're like, "Well, how did you get this information?" I interviewed them for an hour and a half, and I was like, I asked a different question, right? And so one of the things I do think about is tools are generally speaking as good as the individual using it. Not saying I'm amazing, but I'm just that's just like a
Sure.
fact. And when we develop tools, I think that the thing that gets in the way are two things. Number one, the way that they're developed might be sort of like overly researchy, meaning that it's like this specific population who don't have comorbidity, who are, sort of like the perfect candidate to receive this tool. And then we're testing it all in there. And then we give it out in the world, and people in the world are like, this tool is a mess. It's not helpful to me. It disconnects me from my individual. And so it really is, coming back to Candace's point, like who's in the room when you're developing it, but there has to be an iterative process for developing a tool, number one. And then number two, any tool has to be flexible. Any tool that you use has to allow some divergence. Now, researchers hate that. They hate that. But there is no world in which a tool that's going to be effective in the wild, as it were, if you don't have some flexibility here. It's just not gonna, people just are gonna, they're gonna give it, right? And then they're gonna fill out their case record saying they gave it, but they didn't give it. They didn't give that. They gave whatever they do, and then they filled it out based on what they did, right? So it's a sort of give and take.
I was going to add, if it's all right, I agree.
Yeah, of course.
I definitely agree with that. And there's been a couple of papers that were released from the general group from the Youth Suicide Research Consortium that have shown that we don't really have great assessments that are validated among youth of color, among LGBTQ youth. And so it is really difficult in those situations to say, you that we should stick exactly to the letter to every single piece of every single aspect of the tools that we have, if we know that there's some kind of additional context within this individual in their context that we could better assess by being flexible and understanding the cultural background and everything within that. So I do really agree with that, actually, even though, yes, as a researcher, I love when things are neat and tidy. That's not the world that we live in, and that's definitely not um, where we are in terms of the evidence with suicide prevention.
That leads well into kind of a question about kind of that challenging piece of like what level of evidence should there be before really thinking about scaling and deploying and things like that, given the safety issues that are obviously in this space. And it's clearly, as you're pointing out, a problem to like completely develop something devoid of the context that you're going to be actually trying to implement it, right? And scaling and all of those kinds of things can be challenging when we don't have enough evidence yet to like feel confident that that's, from a safety standpoint and all those kinds of things. So can you talk about how you think about kind of that balance and, obviously co-design of who's in the room is one piece of it, but there's also that still those like deployment questions and things like that that need to be considered. And how do you approach those decisions?
I think that's a Candace because she's a researcher. I'm not.
Sure. I was actually interested what you would say, but that's I think it's really hard. So on one hand, especially, it's a very high risk group, that if we think about, we do not want to be giving interventions that aren't appropriately vetted or assessments that aren't appropriately vetted, that don't have a good evidence base, and just releasing them out there. And especially with people who don't have the training or the know-how to actually implement them. There's huge risks that are there. On the other hand, we're in a situation where things are constantly changing, especially technology and the online environments that we're in are constantly changing. And we know there's that kind of famous paper that, or report from the Institute of Medicine, I guess, that showed that there's a 17-year gap from the point
Right.
new interventions developed that it actually gets out there. So we do have to find a line in the middle. And I don't know that it's necessarily like there's this exact point. But I think it's also being careful and thoughtful and practical about releasing things in a way that we have careful management plans in place, that we feel that we have enough information to get an idea of, is this safe? Is it user friendly? Do we have a good idea about data privacy and all of those things? And that we have a plan in place to mitigate potential risks. And I don't know that it's exactly black and white for me, but I think there's a lot to consider and to consider really mindfully. I know Stephen Schuler has a good set of
Right.
commentary around that he's released and done different talks about that. But it's really challenging. There are unique pieces in here and unique angles of thinking about the the risks that can exist to individuals, the potential of what we're doing, of if we're thinking about things that are more in a group context. There's things about contagion that they don't quite exist in other places. There's concerns about liability. There's a lot of different things that, I mean, are true of mental health in general, but the risks are always higher when you're talking about a population of people with suicidal thoughts and behavior.
Sure.
So it's hard, I guess is my conclusion.
Tia, anything you want to add?
The only thing I was thinking about is, most of these tools are developed, and fairly white populations. So
Mm,
I'll say my one plug is that they're often deployed on people of color and never tested on them. And so I think the reason why I'm bringing that up is thinking about how often tools are used on populations that they've actually never really been tested on,
right.
but we're less concerned about those populations, generally speaking, as a field. And so, I think the risk of working with suicidal people is really scary. And I think, it really depends on, from my perspective, the utility of the tool. Like, if we need this thing right now, and then we need it right now, right? We need to figure out a way to make that happen quickly. But doing suicide prevention is actually, in fact, not rocket science. Generally speaking, you have your risk assessment, you have your safety plan, you have all those things. All those things are pretty effective, relatively speaking. And so anything that we're developing is really, to me, going to be sort of new and different. More like online, right? And realistically speaking, to sort of fill the gap, which sort of what Candice is doing, fill the gap of space for people who don't have access to resources. And so that's sort of where we're at. And I'll say, like, I know we'll get into AI, but like, I meet with companies all the time who do all the AI things. And I'm telling you, every 3 months it's something new. And it kind of scares me a little bit about how fast things are changing, especially for people going online for help. And so I'll stop there.
No, I appreciate that. And we will make sure we come back to talk about AI a little bit and some of those other pieces. We have a question in the chat. How do you think we should navigate potential risks with privacy and access in the name of promoting health? I recall controversy with the Go Guardian platform in Maryland related to student surveillance, as well as more recent debates on social media bans that could remove access to potentially vital social supports. Anyone want to tackle that one? And if you want to share any information you have about the Go Guardian platform example that's being raised there.
Oh, yeah, I can find an article and drop it in the chat, but the short version of it was there was this platform called GoGuardian that was put on students' computers, and it was monitoring their searches. And so, um, while it was noticing things related to mental health, it was also intrusive in ways that people did not appreciate, and started a lot of conversations that it seemed like people were not prepared for.
Mm, great, thank you. Tia or Candice, do you want to take on that question?
Yeah, I can start. To be honest with you, I think that some of that of what you're raising, when I go and give different talks across the country and there's, these kind of side conversations, the parents come up to me or teachers, etc. It's often a lot of times about that question of we have this thing at our school, it's monitoring people. And, there was this situation where they showed up to this kid's house. It was a police officer, it was at X time, and it was really scary. And especially, I think from the kind of the lived experience I've heard from um, families of color and just the experience of that and how it really it made them feel a certain sense of fear of what they're putting on their devices. And sometimes it was fairly it was something that was pretty benign, in nature. And in other times, you hear the situations where there was a real risk and it detected it, and that's great.
Right.
It's complicated, and I think it's really hard. We did a national survey to ask people's perspectives on the comfort level that they had, and the individuals who we were really looking at young people who had experiences of violent victimization and if they felt comfortable essentially with um, those kind of reporting systems. And 60% of them also had suicidal thoughts within the past year as well. So they had that kind of history. And really, it was really varied. The LGBTQ youth were the group who were consistently most uncomfortable. And we did qualitative interviews with them, with some of them saying, I'm really worried about being outed. And some of them saying there's real safety risks, unfortunately, of sometimes being outed and what can happen related to that. It's very concerning. There were some other youth who said, that would be really helpful for me. For me, it's so hard for me to reach out. And if someone could just, kind of put that in place, it could give me that kind of opportunity to seek help without actually having to say, hey, I need help right now. So it's incredibly challenging. I do think though that a lot of times how schools are handling that is really kind of an opt-out, or sometimes it's just this is how our school does this. So if you want to be at this school and it's a public school, so this is what we're doing. And I do, to be honest with you, kind of question if we could make it more of an informed consent process, if we can give parents more rights within saying, I am okay with this or I am not, because there's such a black box in terms of how they work. And giving people more rights to say, I'm comfortable with this or not, to me is a direction that I would really appreciate if we could go in. I may have missed another part of that.
I think you covered it well. Yeah. Tia, your thoughts?
So, I think there are a lot of different ways that people's privacies are being violated, sort of like every minute. When you think about, and Phil, you brought up this platform that the school uses, but let's just even start with social media, right? So, owners of social media platforms can see what you're doing, right? They have full access to people's DMs, and right now, their DMs, their search history, and right now the owners of these platforms are doing two things, right? They're monitoring, and then they're also utilizing their data to serve you things, which may or may not be related to suicide crisis. So the reason why I'm bringing up these platforms is on a daily basis, everybody in this room, if you use a social media platform, you're being monitored. This is a fact, right? And if you're putting private things in there, the platform itself is even to this day like making decisions about what they should do about it. If they see that you're making a plan and you're posting, are they going to send police to your house? Or if you're a young person, are they going to alert your parent, right? So there's that way. Another way that people's privacy is potentially being violated is around billing. And so, we have 220 crisis centers in our network, and all of them are answering calls through 988. But all of those centers have multiple lines of business. They might have a local line, they might have a warm line. Some of those lines of businesses are billable, 988 is not billable because it's free. But when people call those lines, right, their CRM are connecting, which is like how they answer calls, connecting the phone number, even if they don't provide name, address anywhere, with their data. And there are certain states that like Arizona that do block billing. And what that means is that they keep track of all the users who reach out to them and then bill to the state, a certain amount of money. Right now, it's block billing, meaning it's not individual, but there will come a time where folks are thinking about when people call crisis lines, 998 or otherwise, that we want to be able to bill, even if it's billed as anonymous, which means that the state then we'll find out about you. And then sort of the third thing is around QI, right? So, states are involved in the QIing of crisis lines, which means they have access to data, not necessarily at the role level data. I feel like I'm scaring people, but this is just a fact. And what that means is that depending on the state you are, where we are now, they're just making sure that the calls are kosher, right? But where we could be in a few years is in states where abortion is illegal. That states are going to comb that data to see who had an abortion and calling about that, or someone who's here, you know, uh, depending on state laws, what they're interested in. And so what that means is that user data becomes less and less safe. And any service, including going to your doctor, as people are documenting interventions in platforms, whatever the platform is, that may in fact be vulnerable. And in fact, we're overly reliant on self-governance for these different platforms slash providers. So uh, I just probably freaked everybody out. So sorry about that. But I like folks to know. I like folks to know.
No, that's fair enough. I think one piece I'm curious, just as a follow-up to that, is part of how I think about these issues of like sort of detection and when to intervene and these sort of balancing acts that people are asking about is some of it depends on like how sensitive and accurate the tools are, right? So if police are only sent to a family's home when it's like actually this was incredibly high risk and you're intervening at exactly the right moment, and then the police are never sent when it didn't need to happen, we'd probably be a whole lot more comfortable. And whereas if it's like really inaccurate and lots of times, harm may be ensuing because it's a false detection, either false positive or false negative. And I'm curious like how you think about those thresholds of like in some ways like what we should accept about inaccuracies or lack of sensitivity
Mhm.
because of the value of preventing harm, even though there's harm potentially on both sides.
I can start. So think about this all the time. So, this is so variable. It's kind of wild, right? So really depends on the state, and the state infrastructure. So do they have mobile crisis? Do they have, it depends. Like if you're in a rural place that has a sheriff, right? So if let's say you're interacting with someone, you end up calling emergency services. They don't have a mobile crisis team. It's a 4-hour drive, all the things. You might have sheriff show up at your door, right? And we've had people, sheriffs refuse to go. It goes both ways, right? So the sheriff
Mhm.
are like, well, we don't want to do suicide by cop. We know what can happen here, and they'll refuse to
Mhm.
go to an urgent place, and people can end up dying by suicide because they won't get the intervention.
Right.
On the other side of it is having someone show up at your door when you actually don't need that intervention. Sometimes there's no in between space. There is no mobile crisis. It's either 0 or 100. And so it really is dependent on location about what type of intervention might happen. And of course, you can't say to yourself, well, I don't want to send, this is a Black trans person who is frankly at highest risk of being murdered or killed by the police. I don't want to send to their house because of their identity. You're actually putting that person at risk because of their identity, right? So it's a real give or take. I'll pass it to Candice.
Yeah.
That was a brilliant response, and I really appreciated all of the insights too. Um, I, I there's I don't know that there's a good, necessarily threshold for the sensitivity and within that. It's it's hard to know exactly. And I think a lot of the tools that we're using, we don't even know what those are, period. So that makes it a whole lot more complicated. Um, there's a lot of variability and I agree in terms of what the response actually looks like. We had a symposium at Pitt a little while ago that was from autistic individuals who had experience having either police or crisis show up to their house, and some of them kind of really walked through the experience of what that's like when there wasn't a person who was really trained in working with autistic people there, and just the sounds of banging in the door and the kind of lack of control and being throughout not given access to kind of a quiet space, and about how that for them was this kind of huge trauma that they looked back on. And so it is really difficult to know what is the best thing to do in that moment. We always want to intervene to address something that is imminent.
Sure.
I also think we have to be careful, though, of thinking like, oh, if there wasn't a risk, no harm done. That's really not
Right.
always the case. And I appreciate the kind of nuanced response of thinking it depends on the situation, it depends on the location, it depends on the resources. It is a really challenging thing. And a lot of the protocols that we have are, just send them out or not, that 0 to 100, which is it's challenging.
No, I appreciate that. We're getting some notes coming in about some interest in asking some of those questions on AI. So I'll turn it over to Catherine.
Thank you. I'm just going to turn my camera. So basically, my question's regarding AI and how accessible it is. Because I don't remember, I think it was Dr. Dole was referencing how kind of AI and kind of digital mental health tools sometimes are thought of interchangeably, and how these tools are very helpful for the people in service or the practitioners who are helping treat, but not the individuals themselves who are suffering. However, due to kind of more socioeconomic barriers, oftentimes people will turn to AI as their therapist. And AI is great for anxiety, depression, but it's been shown that recently, as of now, it's not very effective in suicide. So, how do you think other digital mental health tools could help mitigate this issue so people can learn to turn more to other ones over AI?
Um, I think one thing, maybe I think it would be helpful to level set, right? And Catherine, I love your question. You know, it's like four, right, models, right? Large language models. They all are different, and part of the reason why they are different are the designers. And so when you talk to the designers, each designer again is engaging in self-governance, and each of them are deciding what is their how do I put it? What are their values in terms of engagement with users? And some of the large language models, what they're trying to do is get engagement. They want people to stay on as long as possible. And so the large language model isn't going to engage the individual, which is actually giving a lot of empathy. But not like a real analysis, right? So you're saying like, it sounds like that's so hard. And the person says, well, maybe I shouldn't tell my parents. No, it sounds like you shouldn't tell your parents. And so they're trying to sort of shape the models a little bit to stop doing sort of bad behaviors. By bad behaviors, I mean telling people not to tell people that they're suicidal, by, giving suggestions about how to end your life, by, all these sort of things that put people at risk. But I think where you start to see divergence right now, and I'll answer your question in a second. Well, actually, Candice is better for the digital tools, right? But is that what their long-term goals are, and whether or not they want that person to stay with them. And I won't speak to who is who, but I can say the trust and safety divisions of each of these things are wildly different. And the amount of leeway that trust and safety has is also wildly different. And so I think we're going to start really seeing a split where people are probably going to end up engaging with the one that is more dangerous, frankly, just because of the way that they're creating it. So I think my first thing I would say to you, Catherine, is please just tell everybody to call 988 because they get a real person. They can chat and text it. They don't have to wait, right? They can just reach out. But To your point, people want immediate intervention. So I'm going to pass it to Candice for that part.
Yeah, I think it's really challenging because my gut instinct, I mean, just as a clinician, is that I would love for people to go to 988, to go to someone within their support network, someone at school, wherever that safe place actually is, for them to go to that rather than going to AI. And I think increasingly that's not the reality, and I also think it when we think back to that conversation about how much shortage there are in available mental health providers and all the barriers there, it makes sense that people are looking for other alternatives. Stigma is high. I could go on, but we know, there are valid reasons that people are looking for alternatives, I guess I should say. And saying just it reminds me of some ways of, saying go somewhere else, of, the teen get off your phone, kind of thing that we've heard for years that unfortunately just doesn't work. And so there are, there's a lot of risks in this space, particularly, and it depends on how they're built. It depends on the data that they're based on, how sycophantic they are, which is a lot of what Dr. Dole was talking about, how they're designed in terms of privacy. Are they imbued with any kind of therapeutic ethics, so to speak, so that if they don't know what to say, that it'll pause, that it won't, if it were a clinician, well, it would refer out. Does it do that? Does it realize there's a point in which we need to stop? And what I would love, in an ideal world, is for there to be a human and ideally a clinician in the loop at a certain point, that there's, systems put in place, that there's risk identified, and it gets out of that AI-based model, and that there's a person that kind of jumps in. And it would, I know that's complicated in terms of resources, but I do feel like there are approaches like that that could, increase access in some ways. Or, in the midst of that, for it to go into something that's a lot more structured in terms of giving evidence-based resources that it's kind of set to do, rather than riffing, in saying, coming up with misinformation, or kind of going down a pathway with someone that's really, kind of concerning, or adding to their suicidal thoughts or their level of risk in that kind of state. So I do, really worry a lot about the models that are out there that people are using every day, and would love to see there be alternatives that have better risk management plans that are in place, that have actual clinicians that are involved. But I guess the optimistic part that I will say, in the midst of a lot of challenge within that, is that things are rapidly advancing, and they can rapidly advance for good too. So there's a lot of caring people in the space who want to do something. And so I'm hopeful that we can see some change, and see the opportunity that comes with this in terms of access really being met with a good safety management plan, as well, so that we can see some good come from it.
Can I follow up on that? Because I appreciate both of your responses very much. Every single day there's news stories about the debates going on right now about what regulation should happen, state level, federal level, what should happen internally to the company, all that kind of stuff. And as you pointed out, Tia, like wild variability and trust and safety going on. If you could, sort of control that regulation, what would you be recommending should be happening at this time? Specific to, not AI in total, but AI in this space of thinking about mental health and suicide prevention.
I think what I would recommend is not what would happen. So I won't bother, right? I think, I was at this conference with a bunch of AI people, and I gave a talk where I feel like I shamed them, which is not my intention, but it is what it is. And what I said to them was, when you all are designing something, you have to inoculate it against your departure. There's a lot of turnaround with these things, right? I'm talking 18 months to 3 years. If you're higher up and you're not at the tippity top, you are gone, right? And so, what can you do to create some sort of consistency across leadership to do this thing? But I think controlling AI is not a realistic thing. But if I had my druthers, that every time you're interacting with ChatGPT or Gemini or whatever the thing that you're using, that whenever you're having a conversation with it, it had in parentheses, I am not a human. That like what happens is people, I think the usefulness of any type of intervention, peer, clinician, anything is like that human to human connection. I think it's super important. And I think when people forget when they're interacting with AI, they forget that it's not real. And in part because it's learning from you and using your own voice. So it's using a voice that feels good to you because it's your voice to a certain extent, but super like supportive. And so I wish that, I would waste a wish on this. I wish that all the interactions, especially around mental health stuff, that the AI is constantly reminding you that it's not real.
Appreciate that, Candice.
Just got a little notification that my internet is unstable, and I didn't hear half of that, so I apologize if this is not at all related. But yeah, I mean, it does feel like we're kind of in the wild, wild west in terms of regulation. And especially when we're talking with people who are actively experiencing suicidal thoughts and behavior, it feels like that's the area in which we should invest in having better regulatory pathways than we have. Probably, I don't want to say more than any other, because there are a lot of aspects of mental health and health in general that matter within this space. But at the end of the day, we do need better, I think, transparency in terms of what is actually really happening, which we don't always have that information, and a better understanding of what are the response plans that are in place and how are they actually how are they working and how are they working consistently. I would appreciate just having more transparency and requirements for reporting around that. And I also acknowledge that there's a lot of really great innovation, and it's not my intention in saying that to stifle any of that. And at the end of the day, I think there's a difference in terms of the safety piece and thinking about where we are and where we could be in terms of setting up regulatory pathways related to that.
I appreciate that. I have a question for each of you that goes right off of what your last line there of not regulatory pathways, but like where we are and where we could be kind of questions. Tia, I was really moved and excited by the data that came out in JAMA about sort of the utilization rates and just really, really exciting. And part of what I wonder about is how do you use that data to think about what you do for the areas that have lower utilization? And so how are you approaching that piece of it? Because you have this evidence coming out of like, it matters if you do this, and how do you leverage that? And often evidence is not the most compelling thing for, for change. And so can you talk about, yeah, how are you approaching that?
I mean, it's so interesting because, there's a lot there. When states who invest in marketing, you see, like, we actually immediately see an increase in volume, right? So when the state does marketing, we can see it. It was so interesting. It was kind of funny. I don't know. Have you all heard of what Grindr? Have you heard of
Yes.
this? It's like a dating app for gay men. And we started advertising on Grindr. And I mean, it was like an increase in volume, 10,000 a week, right? It was wild. And in part because of the dynamics behind Grindr, which people feel terrible about themselves. It's the whole thing. If they see it, they use it, right? So it really is, it's just about awareness. There have been a few studies where people are like, oh, 75% of Americans have heard of 988. That doesn't mean they know what it means, and how it works. And so, I'll just say it's pretty simple response, which is like in those states where they have low utilization, we need to figure out a way to speak to people. And every campaign is different. My favorite campaign was in Louisiana, um, which was like feeling swamped. Reach out to 988, which is like so regional, right? And I think
Yeah.
that you have to think about who your population is. If you have just general, comms, like people aren't going to reach out, right? It has to be specific and it has to speak to them. And some of the campaigns don't even use the word suicide, right? You use overwhelmed, stress, things like that. Because if you use the word suicide, especially in more religious communities, you're going to run screaming from it. And so it has to be specific to that community.
No, I love that. And I mean, I wake up at 3 a.m. with different state slogans in my head coming to mind. That's great. Ken, is a totally different question, but also in the like, how do we get from where we are now to where we want to be? And I'm wondering if you can give advice. We have, I recognize a number of the names that are listening in here, and we have some amazing early career folks who are attending this thoughtful presentation that you're doing and discussion. And many people are feeling pretty disillusioned right now with the current federal landscape and what it looks like for funding and what that means, particularly for our ability to do the research on equity in these spaces and being able to increase reach. And I'm wondering what advice you have, how you can encourage people to keep working in this space as we try to keep learning and growing and improving what we do during challenging times where some of the federal support may not be in place.
I appreciate that question because I think it's the dark cloud that's hanging over a lot of us. And I think in a lot of ways, keep going because the work that we're doing is more important now than maybe it ever has been in some ways. To keep caring about the populations that we know are disproportionately experiencing suicidal thoughts and behavior, that have less access to mental health resources, to quality care, that haven't been included in a lot of ways in the evidence-based interventions or in assessments that we have. To reach out to those within your support network so that you're not feeling alone, and to come at all of this together. There are grants being funded. There are people doing amazing work. And a lot of it is, coming together to learn what we can about the best approach to think about funding within an environment in which that's really challenging. It's not straightforward. This is really hard. If you're feeling like that, my goodness, you're not alone. But to keep fighting for what's the good that we can have in the world. And at the end of the day, I think that's a really huge protective factor for a lot of us. It might even be a reason to kind of keep going in this world, is to bring about that change. So we will do it, and we can do it together.
Can I answer that too?
Yeah.
Okay. There's a difference between the current administration and the federal government. The federal government is staffed by mostly wonderful people, especially Health and Human Services and SAMHSA, right? Those are lifers. Those are lifelong people who have spent their career in service, and they are fully aligned. They know that this is important, and not for nothing, we just received, $255 million a year from this current administration 1 month ago exactly. So I think there's two things at play. I do think that in terms of prevention nationally, we are all finally rowing in the same direction. I think that folks have a real idea what works, what doesn't work, where are the gaps, what do we need to do? Great. Versus like 10 years ago, where I thought it was very fragmented. Number two, this administration um, has invested, right, in suicide prevention in part, right? And I don't want to knock on wood. I don't want to say anything that's going to blow my spot up, as my children would say. But this is truly a bipartisan issue. And I think that the value of suicide prevention is SPRC, which is a Suicide Prevention Resource Center, received their funding, right? 988 received their funding. The federal government just released a bunch of NOFOs. It's the one thing, I don't know if you can hear me knocking on wood, it's the one thing that is still going. And then number three, again, federal staff, they're fantastic. They know what they're doing. The people who aren't going to leave, they're not leaving, and they are heads down. And frankly, like our grant program officer, this is his fifth administration. He's still there, right? So just I know everything feels very stressful, especially as a clinician and or doing any type of work that you're doing. But trust me when I say that I actually feel okay for now. And I do think that this is probably one of the few things that everybody's like, you know what? Okay. This suicide prevention seems like the one thing we should all get stack hands on.
Well, on that note, a huge please, everyone, join me in thanking Tia and Candice for a fabulous conversation today. Unfortunately, we are at 3:50, so we need to wrap up. Thank you to all who were raising questions. I'm sorry we didn't hit all of them in the chat, but huge thank you for the thoughtful discussion.